Now I'm going to take a listen to your lungs. So when you feel me touch you with the stethoscope, I want you to just take a nice deep breath through your mouth.
Here's some good news. New data from the Canadian Institute for Health Information says the number of family doctors and nurse practitioners is increasing across the country.
Manitoba is gaining more doctors.
We've added more than 12,500 doctors in Ontario with another
84 net new doctors to New Brunswick.
The bad news, it's still not enough to meet the growing demand for healthcare.
Canada is burning through its young nurses at an alarming rate and struggling to retain them.
Not enough to replace the workers retiring or the ones lost to stress and burnout.
Are you pushing the staff that you already have too far?
Everyone here works to their capacity, and sometimes they push themselves, to be honest.
And not enough to catch up with the 5.7 million Canadians who still don't have a primary care provider. This is just one of the highlights in CIHI's State of the Health Workforce Report, a snapshot of a health system struggling to keep up. So on this episode, we'll explore one way of easing pressures on GPs from an aging and injured population, a trend that's growing in Canada and other parts of the world.
Meet our first contact physiotherapist, one of our extra healthcare professionals.
Adding physiotherapists as first contact in family health teams for patients with back and joint pain, arthritis, and sports injuries, instead of having them wait to see a doctor.
Everyone is keen to find solutions to the primary care crisis. And so I think that this is actually the time for us to really leverage this first contact role of physiotherapy, not because it's a nice to have, but because it's actually a need to have.
You'll hear from Emily Stevenson with Ontario's Physiotherapy Association about studies showing first contact physiotherapists can help patients faster and at a lower cost to the system, with a goal of freeing up doctors for other patients in need. Welcome to the Canadian Institute for Health Information podcast. I'm Avis Favaro, the host of this conversation. A note, the opinions here don't necessarily reflect those of CIHI, but it is an open discussion, and this episode is talking about first contact physiotherapy and why some believe it's another way of tackling the primary care backlog. And joining us now from Toronto is Emily Stevenson, Director of Practice and Policy with the Ontario Physiotherapy Association and a registered physiotherapist. Welcome, Emily.
Thank you so much, Avis. It's lovely to be here.
Good. So we are talking a lot about the latest CIHI workforce report. It's clear that there's a strain in the system. So the question is, if a lot of people are waiting for care, are there other options? And it turns out that 20 to 30% of people go to the doctor for back pain and joint pain and other injuries. So could those patients be seen by a physiotherapist first? What do you say?
I say absolutely. This model of what we call first contact physiotherapy is one that is growing actually across the country. Physiotherapists are trained to be experts in the assessment of musculoskeletal conditions, as well as the management. And so allowing patients to be able to be seen first by a physiotherapist for the management of these conditions is a great way to really offload the pressures of the system.
And what kind of conditions are we talking about?
So the most common condition that's seen in primary care is low back pain. So low back pain, shoulder pain, knee pain, and a lot of these pain issues are related to osteoarthritis. Some of them are related to other wear and tear on the joints. Some of them are related to sedentary lifestyles. A lot of individuals are sitting at computers all day long, and so they're developing pain.
Sure are. Yeah, they sure are.
Like you mentioned, 20 to 30% of visits to primary care are related to musculoskeletal conditions. And the reality is that physiotherapists are really the health providers who have the training and the expertise to be able to manage these individuals.
So you were a practicing physiotherapist for a while. So this idea came up and you were among the first to start using it in Toronto?
That's correct.
And you said, okay, rather than send this patient to the doctor first, send them to me and let me do the assessment. What happened there? How did that unfold?
Yeah, that's exactly right. I was working at a community health center where we were looking at ways to improve access for our patients. How do we get patients seen faster? And so the trend that I noticed was that patients who were being seen by a physician for a musculoskeletal condition, such as low back pain or knee pain, would be just referred directly to physiotherapy. That was the pathway.
They had to wait to see the doctor, and then when they saw the doctor, they were referred to you.
That's right. So they were really waiting twice, right? Waiting to see the doctor, then waiting to see the physio. But what I realized was that, well, physiotherapists are direct access providers. We are trained to make a diagnosis. We're trained to rule out red flags. And so I made the suggestion to the team that when patients are calling in for low back pain or for knee pain or for neck pain, why don't we just book them in directly with me as the physiotherapist? And the doctors were thrilled. They were very happy about this.
So some people might say the doctors would say, no, I need to see them first. They were happy. Why? What were you offering them?
So I was fortunate to be in a team where the physicians were really open to that idea. And so for them, knowing that these patients could be seen by a physiotherapist who could not only provide an assessment, but also provide effective management for that condition was a real, weight off their shoulders.
So what happened when you started doing this?
I would say the one thing is that patients were seen faster. So I was able to see them faster, which meant a faster diagnosis and also faster access to treatment. So overall, we were catching and treating conditions sooner, which meant that their outcomes were better. The other thing that I would say we saw was that we saw a real reduction in terms of the amount of diagnostic imaging that was being ordered. X-rays, ultrasounds, MRIs, primarily because the population that we were working with didn't have access to physiotherapy. And so the physicians were using diagnostic imaging to help them be able to understand what was happening. But at the end of the day, a lot of that imaging actually wasn't really necessary for the condition that was being treated.
So fewer tests, okay.
The other thing that the physicians reported is that there was less pain medication that was being prescribed. Because again, these individuals were able to access the therapy that was needed. And so then there was less of a reliance on pain meds.
Anything else you noticed?
There were fewer patients who were being referred on to see specialists. So I often found myself in a situation where I would be, prior to this system being implemented, referred a patient who had an X-ray and an ultrasound and an MRI, and they were waiting to see an orthopedic specialist. But I can't tell you the number of times when I would see the patient for 1 or 2 sessions, and they would come back to me and say, you know what? I've taken myself off the orthopedic waiting list. I really don't need to see them anymore because my pain is resolved.
Wow. What did you think when that happened?
Well, I thought, this is incredible because we're saving the system, right? That appointment, we are providing the patient with the care that they actually need. And it made me realize that there's a lot of utilization of the system that if conditions are actually properly managed upstream in a primary care setting by the appropriate provider, it's actually going to decrease a lot of the system costs that we see further on down the line.
Why were you able to do that in 2015 and we don't hear much about that now in 2025?
Yeah, it's a great question. And I think, there is growth of physiotherapy presence across primary care teams in the country, which is wonderful to see. We know that especially in PEI and BC and Quebec, we are seeing more and more of this model. Within Ontario, I would say we're at a great place right now where the province is looking to increase access to interprofessional teams. And so I think we are at a point where hopefully it's happening, but it just hasn't yet become the standard of care.
Now, people do have access to physiotherapists. If they have insurance, they can self-refer, right? You can just go. But a lot of people can't. You're talking about physiotherapists that's built into family health teams.
That's right. Exactly.
On staff.
Correct. So physiotherapists are hired by the primary care team. They're salaried positions. They work very closely with the rest of the interprofessional team. And like you said, there's a large segment of our population who cannot access physiotherapy because they either can't afford it or they don't have extended health care. And so by embedding a physiotherapist within these teams, it actually provides access to a large segment of the population who otherwise would never be able to access care.
So we spoke to a family doctor who's part of a very large family health team in downtown Toronto. And a couple of years ago, they hired 2 physiotherapists to serve, if needed, as this first point of contact for the right patients. And here is what Dr. Alexander Glover had to say about the experience so far.
I would definitely say that it is a good program that frees up time for the physicians. And while the physician is included in sort of communication, as long as a physiotherapist is satisfied with being able to manage things themselves and don't need any extra support, then the physician is never involved.
Would you encourage other family health teams to look at this model?
Absolutely. I would imagine that other teams would be like clamoring to get the funding to be able to support this. And as with all changes, it takes a little bit of getting used to, but I think, again, because we work in such a collaborative team, like I've never had any concerns about it.
Do you ever have the patients go, no, I don't want to see the physiotherapist first?
That's fine. I'm happy to see that patient, but it might mean that the patient's waiting longer. But if that's their choice, then that's okay by me.
So you can get them care faster.
That's one of the major goals, is that they're able to be slotted into the physiotherapist's schedule that has protected urgent care slots. So they're able to see the physiotherapist much faster.
So, Emily, have you done any calculations to find out if this physiotherapy as first contact saves money? Does it get more people into the physician?
So there's been a lot of research done on this model internationally. And what they have found, primarily in the UK, as well as in some of the Scandinavian countries, that there's definitely a reduction in costs with this model, that patients are seen faster, and that some of the benefits that I've already spoken to are also realized.
You have some data from Ontario when you were looking at this. What did you find in terms of how much pressure it took off physicians and what the benefit to the system was?
Yeah, absolutely. So we evaluated the impact after the first year of implementation of the expansion, which was in 2017. One of the most interesting findings was that it improved their own satisfaction in terms of care delivery. Knowing that they actually were able to connect their patients to the services that they needed.
If you free up physicians, because they don't have to deal with is 20 to 30% of people who have these issues, these physical issues, they have room to take care of other patients or see other patients. What did you find with that?
So some of the work that we have done most recently has been to look at what is the number of patients that a physician could take on in terms of their roster if they had a physiotherapist working as a first contact. We used the number 1,800 because that was sort of like a middle of the road roster size of patients for a physician. And we calculated that you could add an additional 450 patients more. So a roster size are not necessarily individuals that are seen in a certain amount of time, but they're the number of patients that are attached so that then when they do need to be seen, they are connected to that physician, to that team to be able to access care.
I can hear government officials saying we can't afford to do this, to put more people on staff in health teams. What would you say to that?
Well, we say that the government can't afford not to do this. The cost of having a physiotherapist deliver care versus a physician is significantly less. And more importantly, it's actually the right provider to be able to provide the care that's needed.
What about physicians who say, no, really, I need to see the patient and I need to assess what they need, and then I'm happy to refer to a physiotherapist?
So there have been studies that have been done to show that physicians working alongside physiotherapists, looking at what their outcomes are in terms of their assessment, are very, very comparable. And the reality is that with working within a team, physiotherapists, if there is a concern that needs to be seen by the physician, they can then go back to the physician and involve them in the care. But the findings in the UK on that have found that less than 1% of individuals who are seen by the physiotherapist in a first contact role need to actually be seen again by the GP. And so really the care can primarily be managed by the physiotherapist. It's very rare that the physician needs to be involved. The other piece that's connected to this is around diagnostic imaging. So the one time really where physiotherapists may need to involve a physician is if there needs to be additional imaging or if there's a recommendation that the patient needs to be referred on to a specialist. However, we are really encouraged right now that in Ontario, they're reviewing the scope of practice for physiotherapists as well as other professionals. And we are hopeful that the addition of diagnostic imaging within the physiotherapy scope of practice would really only serve to optimize this role.
Now, can they not order tests in other provinces?
Yep, they can. So Quebec, PEI, and Alberta and BC have all moved ahead with physiotherapists being able to order diagnostic imaging.
And that is why those provinces have more physiotherapists as the first contact.
That's correct.
And your colleagues in the other provinces that do have physiotherapists as the first point of contact, what do they say about the benefits?
So I just had a conversation this morning with a colleague from PEI who was saying that they have expanded quite rapidly in terms of having physiotherapists working in this context, and they are finding the same outcomes that we have seen too. But there needs to be the will on the part of the government to be able to put the money there. And I think that's what PEI has seen, is that the funding has been there, and so they've been able to actualize the model.
So you started years ago with this idea, and here you are now hoping to see it expand. Does it feel frustrating, or do you feel hopeful?
I think, unfortunately, it sometimes takes a crisis for people to really look at new and innovative ways of working. And I think, everyone is keen to find solutions to the primary care crisis. And so I think that this is actually the time for us to really leverage this first contact role of physiotherapy, not because it's a nice to have, but because it's actually a need to have.
Well, thank you very much, Emily. I appreciate you talking to us.
Thank you.
A note, there's a study in Ontario and BC that will provide more data on this first contact approach in a Canadian context. Meanwhile, you can read much more about the state of our health workforce report on the CIHI website at CIHI.ca. I'm Avis Favaro. Thank you for listening, and talk to you next time.